This is an awesome conference. Thank you guys for coming here, and thanks, John, for inviting me. We get to start off this afternoon with the sports cardiology topic, which is my favorite. And so today the objectives are to look at acquired arrhythmias and cardiac disorders and look at how they relate to athletes, think about different types of congenital cardiac conditions. We're going to look at different EKG changes that occur with cardiac conditions and then discuss the athletic heart syndrome. Whenever we think about sports cardiology, or at least whenever I'd been young and thought about sports cardiology, I thought about sudden cardiac death and I thought about young athletes, but we have to remember that sports cardiology is a really broad topic and also includes the older athletes. So whenever I do the sports cardiology talk, I always want to remember that arteriosclerotic coronary disease is a huge part of sports cardiology. So in athletes greater than 35 years old, 80% of sudden cardiac death are due to coronary artery disease. 50% of people have prodromal symptoms, and oftentimes the risk factors include the common things that you guys might think about, so hypertension, smoking, diabetes, hyperlipidemia. So if we start with hypertension, there were some recent guidelines that came out from JNC 8. They sort of reaffirmed what they had talked about in JNC 7 in terms of some of the what are the cutoffs for normal, pre-hypertension, and hypertension. But the one thing to note on here is that there is a different cutoff for people generally over the age of 60 years old, that the cutoff is for most individuals 60 to 79 years old is less than 150 over 90, and then really for all people over 80 it's less than 150 over 90, but the normal cutoff is going to be 140 over 90. And then remember in children that they don't necessarily use the cutoffs, they look at percentiles, so greater than 95th percentile is considered hypertension, and then 90 to 95th percentile is pre-hypertension. Whenever you're thinking about high blood pressure, it's always important to remember that how you measure blood pressure is critical. So we've actually done some projects looking at just how do people measure blood pressure when they're in a family medicine clinic. And we found that just getting people to do the measure accurately portion, so having patients sit down quietly, avoid caffeine, make sure you have a bladder cuff that encircles the arm in an appropriate way, get greater than 2 measurements to make sure that you can confirm the diagnosis of hypertension. This actually doesn't happen that often, but it's actually very important when you're trying to make the diagnosis of hypertension. Remember to think about the history. So if you have an athlete or you get a board question, try to look at the history. So are people using sympathomimetics? Do they take supplements? Are they taking NSAIDs? Alcohol use or drug use such as steroids or amphetamines. So the history is critical, as is the physical exam when you're trying to rule out secondary causes of hypertension. So do they have Cushing's disease, signs of hyperthyroidism or hyperparathyroidism? Do they have Bruey, so renal vascular stenosis, or potential coarctation? So the history and physical exam are really critical when you're looking at hypertension. You can get different lab tests, so checking the thyroid, looking for things like hypokalemia that you might see associated with aldosterone excess, getting a serum calcium, which could be associated with hyperparathyroidism, looking at your kidney function, and another way to assess kidneys through a urinalysis. So lifestyle measures, there's a huge growing field of lifestyle medicine that many people are sort of getting into, and this is a key area in sports cardiology actually. So trying to get people to take care of themselves, getting them to exercise, to make sure that when they eat nutrition, they eat healthy, have a low sodium diet, and potentially have a lower alcohol intake. Those things can help with just hypertension in general. When we're thinking about hypertension treatment, so if we go past the lifestyle measures and we start to think about medications, there are different areas or different medications that you can think of, including thiazides, ACEs and ARBs, calcium channel blockers, and beta blockers. It's important to note that thiazides are banned by WADA, so a lot of people try to use it in doping to cut weight in things like boxing and wrestling, because it can help them cut weight, but also can dilute urine and can mask ergogenic aids. So thiazides are actually, again, banned by WADA, and then beta blockers can impair athletic performance, and so they're banned in precision sports. So if you can think about rifle, for example, that can be a sport where you're not allowed to take beta blockers. So that's it. It sort of leaves you with the medications of the ACEs and ARBs, as well as the calcium channel blockers. And then to remember that the ACEs and ARBs, in 10% of people, they can get a dry cough as a side effect. That's something to keep in mind in case that comes up. Atrial fibrillation is another interesting sports cardiology topic. It's the most common arrhythmia in athletes, and if you're going to get a question on this, the typical person is going to be a middle-aged endurance athlete. In atrial fibrillation, we're trying to figure out what the exact reason is for the increased incidence of AFib in endurance athletes, but the potential causes are potentially due to one of three reasons. So one is the morphologic substrate might change. Two, there may be differences in the autonomic system, so if you're looking at the balance between parasympathetic and sympathetic activity. And then the last is potentially a contribution from just having chronic inflammation. But there have actually been some really good studies that show that the more you exercise, actually the higher your chance of getting atrial fibrillation. So this study that came out in 2009 showed a relative risk of developing atrial fibrillation was 1.74 in people less than 50 years old for people who exercised compared to those who didn't. And people who exercised more, so if you look to the far right, people who exercised in the 5 to 7 days per week realm had a higher incidence of AFib compared to those that exercised less. So there are different terms that sometimes people, they sort of get confused, but remember the term lone AFib is dealing with someone who has no structural heart disease or underlying condition, versus older athletes might have AFib that's commonly precipitated by things like hypertension or coronary artery disease. So with AFib, I think many of you guys know the common symptoms, so palpitations, shortness of breath, some chest discomfort. And similar to what we did with hypertension, we want to get some labs, and those will include looking at the thyroid, getting an ECG, getting an echo, and then you can do a 24-hour Holter test, exercise stress test, really to determine the ventricular response when you get AFib. That's something that actually is important to do in both AFib as well as things like Wolff-Parkinson-White, which we'll go over here in a little bit. So with AFib, there are different ways to treat it. Again, beta blockers are one form of treatment in the general population, but again, they may be prohibited in the sports that you may be, the athletes that you may be caring for. So calcium channel blockers are another option. Then for people who don't get it that often, there's something called the pill in the pocket. So if you're looking for rhythm control, the pill in the pocket with type 1C antiarrhythmics are somewhat of a common practice when you talk to some cardiologists. When people have AFib, it's important to assess the need for potential anticoagulation. So if you are doing that, you're going to use the CHADS-2 or the CHADS-VASC score, and you'll be able to assess, again, whether or not they need anticoagulation. And you sort of have to, when you're counseling the athlete, think about anticoagulation versus bleeding risk. And then you'll have to have a conversation about whether or not, if that athlete is doing collision sports, whether or not they're going to continue to participate. If they have AFib and you can ablate it, then that's good. And oftentimes people, if they have an ablation, they have no recurrence of their AFib, they can oftentimes get back to their sports in about 6 weeks. So I wanted to go through some test questions as we go through some of these talks. So this is a test question that you might see. This is a 26-year-old male marathoner presented with 3-week history symptoms of progressive fatigue and exercise intolerance after a flu-like illness. His evaluation leads you to make the diagnosis of viral myocarditis. According to the 36 Bethesda guidelines, you should recommend that he withdraw from sports and undergo a prudent convalescent period of approximately how long? So if you're thinking about 1 month, 3 months, 6 months, or never returning to sports. How many say 1 month, 3 months, 6 months, and then never return? So the answer is 6 months. And this is actually a common thing that you might see. Actually, when I think Dr. Finoff, when he was talking about one of the studies I was doing, was looking at the psychological impact of being diagnosed with cardiac disease. There's actually an athlete from Minnesota several years ago who was diagnosed with viral myocarditis. Really healthy guy, got flu-like illness, and then all of a sudden started getting short of breath over several days, weeks, and ended up finding out that he had viral myocarditis, and he was out for 6 months. And people, when they're out and they're seniors and they can't play, that sort of leads to different things. So that was part of that study, and why we talked to him. So it is common. It's actually 7% of all sudden cardiac death in athletes are due to myocarditis. And unfortunately, sometimes the symptoms of shortness of breath or progressive fatigue, that may not be the case. Actually, sudden cardiac death may be the first manifestation of their disease. So with myocarditis, you can get an ECG. There's oftentimes sort of non-specific ST or T wave changes that sort of correlate with the severity of their disease. So in mild cases, you may not see a whole lot. You may get an echo, which again in mild cases may not show you a lot, but you could see reduced ejection fraction and function. And you may get cardiac enzymes just to evaluate, and they may or may not be abnormal, but that's sort of the workup that you'll do. And once you diagnose somebody with viral myocarditis, again, abstaining from strenuous exercise for 6 months is the typical recommendation. So here's another potential cardiac condition that you might see. So imagine that you're covering that event. Again, these things happen in young kids with thin, compliant chests. Chlamydia cordis is a potentially common event that you might see. We actually have had several cases in the AMSSM conference where fellows are covering events, and they've been fortunate to save lives because they've had AEDs nearby after an event like this. So this is blunt trauma to the chest. Leads to VFib and potentially sudden cardiac death. And the mechanism is that there may be a vulnerable window when you get hit just before the peak of the T wave. Most common in children and adolescents because they have a thin, compliant chest wall. And then there may be projectiles. So in this case, it was karate, but you can think of somebody playing baseball, field hockey, lacrosse. And so there have been some people who try to advocate for wearing chest protectors, and there hasn't been a lot of good evidence to show that these things work, but that is something that people have thought about and you may see out there. Again, be ready. If this ever happens, make sure you have your emergency action plan in place, because unfortunately from these events, there's only been a 15% survival in the literature. Emergency action plans and AEDs are critical in saving lives for these people. Here's another test question. We've got a collegiate rower, comes to your office after exercise-associated syncope. Your workup includes a detailed personal and family history and further cardiovascular testing, including an ECG and 2D echo with color Doppler. Which of the following favors a diagnosis of athlete's heart versus hypertrophic cardiomyopathy? So how many would say left ventricular cavity dilation? Altered echo parameters and first-degree relatives, ECG patterns including extremely elevated voltages, Q waves, and negative T waves, maintenance of wall thickness after deconditioning, and then marked left atrial enlargement. So in this case, the answer is left ventricular cavity dilation. So when we think about the athletic heart syndrome, again, this is where the heart gets bigger, but in a nice way. So the LV wall thickness increases, the cavity size increases because it's going to allow you to pump more blood effectively and efficiently into your body. And you're going to have increased diastolic filling. So when your heart relaxes, it's able to fill up more. And that's very different than if you look at this picture, which I think sums up what you might see in hypertrophic cardiomyopathy, where the wall thickness increases, but it's asymmetric. And if you look at that cavity is actually smaller than somebody who has an athletic heart. So when you're looking at the athletic heart and you're trying to figure out, okay, on an echocardiogram, does this favor athletic heart versus hypertrophic cardiomyopathy? Typically, you're going to see a left ventricular wall thickness that might go up to 12 millimeters. And then there's sort of this gray zone overlap between the two that's between 13 and 15 millimeters, where sometimes it's hard to tell the difference. And then typically over 16 millimeters, that's when you really get into, I think this is hypertrophic cardiomyopathy. So if you're, again, trying to differentiate the athletic heart versus hypertrophic cardiomyopathy, you can look at the left ventricular end diastolic diameter, which is going to be bigger in the athletic heart. Oftentimes it's greater than 55 millimeters, and it's going to actually be smaller, as in that picture that we saw, in hypertrophic cardiomyopathy, oftentimes less than 45 millimeters, associated with impaired diastolic function. There's some new and emerging techniques to try to differentiate the two, athletic heart and hypertrophic cardiomyopathy. Oftentimes in the past, people had to rely on things like deconditioning the athlete, which people don't do as much now. But there are new things like doing tissue Doppler that can help you figure out if people have abnormal filling or impaired relaxation of the left ventricle. And then things like cardiac MRI that come out. And when you do gadolinium enhancement, oftentimes you'll see fibrosis or scar tissue in hypertrophic cardiomyopathy. So this is a really good tool when you're trying to differentiate the two if you're still struggling. Other things that you can do is look at the family history. So in somebody who has HCM, that's going to be an autosomal dominant disease. So somebody might have a family history of sudden cardiac death. People who have HCM, oftentimes if you do cardiopulmonary exercise testing, their VO2 max ends up being a lot lower than you might see for an athlete that's really at a high level. So we had a basketball athlete, collegiate athlete, played at the highest level, and when we were trying to figure out if he had HCM versus the athletic heart, his VO2 max was in the high 30s, which you wouldn't really expect for someone who's an elite basketball player. So this is actually a test that we use quite often. Genetic analysis out there, it's not perfect, it's costly, but it is something if you can identify the gene that someone has in their family for HCM. And then detraining, again, don't necessarily use it as much anymore, but that's something that on historical tests people have talked about. I pulled this from the Bruckner and Kahn book on clinical sports medicine. I think it's a really good image to help you try to differentiate athletic heart from two key cardiac diseases that you want to think about. So HCM is in the bottom right, and then ARVC is in the bottom left, so arrhythmogenic right ventricular cardiomyopathy. There are kind of gray zones between both of those and athletic heart, and the key differentiating features are summarized here. So when you go back to study, if you want to try to remember what it is that I've been talking about, I think this is a really good image to help summarize that for you. And we'll talk a little bit more about ARVC in just a moment. So the next one we're going to talk about is anomalous coronary artery disease. And again, this is another one that's really tricky, and I would tell you actually this is the condition when I'm trying to take care of athletes that I get scared of the most, because it's one that's not very easy to diagnose. So people might present with exertional chest pain, and the trick is, are we trying to figure out how do you diagnose this anomalous coronary artery, and you sort of have to have a low suspicion for that. So the more deadly anomalous coronary artery is going to be when the left coronary artery, so the left coronary artery is going to help supply the left ventricle, so that's obviously really important. So if the left coronary artery is coming from the right side, that's going to be really bad. And you can see in the top left what happens is you basically get into an area where it's going to get squished, and when that's the case, that can lead to sudden cardiac death. Fortunately, that's not the most common one. It's actually the most common one that will present is the right coronary artery coming from the left sinus, but the more deadly one is where the left one comes from the right side, because again, it's supplying the left ventricle. So again, this diagnosis is really difficult. In young kids that have thin chests, you can try to get your techs to try to evaluate the origin of the coronary arteries, and that's oftentimes, again, easier in someone with a thin chest. But in older individuals or people who aren't thin or who might be obese, this is actually going to be really tricky. And so if you have suspicion of this, getting a CT or MR angiography is probably the modality of choice. Once you find somebody with this, they're out of sports, and if they get surgically corrected, then they can come back after a minimum of 3 months is oftentimes the recommendation. So here's another test question. We've got a 19-year-old basketball player, has an episode of unexplained syncope during practice. Patient says he doesn't have any previous cardiac history. He thought he was just dehydrated. He admits that he had a cousin that died at the age of 20 from cardiac causes. EKG is obtained. Which abnormality would be suggestive of right ventricular dysplasia? So we're going to talk a little bit about ARVC here. So normal EKG, T-wave inversion, prolonged QT interval, Q waves, and then pre-excitation. All right, so the answer on this one is T-wave inversion, and you're oftentimes going to see that maybe in V1, V2. The trick with that when you go with ARVC is oftentimes T-wave inversion in V1 is going to be normal, but in someone who has V1 and V2, you sort of have to keep this in the back of your mind, which when you look at the ECG criteria, the Seattle criteria, we'll go over some of these. This is, again, the disease that gets a little tricky because there's oftentimes overlap between this and what might be normal in an athlete. So if you sort of think back to ARVC, this is a mutation in desmosomal protein. So the desmosomes, that may be your trigger in your stem of your board question, predominantly affects the right ventricle, but it can actually affect the left ventricle. And then what happens is you get this fibrofatty replacement in between the cells. And if you imagine an electrical impulse that's coming through on your heart, when it meets this fibrofatty deposition, it sort of hits that fibrofatty area and says, I don't know what to do. It short circuits and it leads to sudden cardiac death or arrest or death. So that's your substrate for your ventricular arrhythmias. And again, it's affecting those desmosomes. So here, T-wave inversion in V1 through V3 is going to be the way that you might find this in athletes. You're going to see things potentially in your board questions that talk about epsilon waves, which we're going to show you is going to be a little notch that's kind of tricky to find, so you really need to pay attention to it. And if you have somebody who you think may have ARVC, you're going to get something called a signal averaged ECG. And so imagine that you get an ECG that over time, all of those ECG patterns they're averaged together, and you're going to see if there are any discrepancies in the QRS complex. And if you have one that has late potential where there's a big discrepancy, that's how you can help diagnose ARVC. So it's not a common thing that you'll do this in conjunction with a cardiologist, but these late potentials on a signal averaged ECG, this is a potential question that you could see on ARVC. So the purpose of this slide is really to show you, is to show you in panel B. So in V1, you can see this sort of notching that occurred. That's the subtle epsilon wave. And again, if you're not familiar with it, it's worth seeing a few ECGs to see where that notching occurs. And if you ever have a question, this is one that you can throw to your cardiologist and say, hey, do you think this is actually an epsilon wave? And oftentimes that's going to be accompanied by, as you see in panel B, T-wave inversion in V1 through V3, and that epsilon wave is oftentimes in V1. This ECG is showing you a couple things. You're going to see what's called a delayed S-wave upstroke, which is the arrow there. And that is something that oftentimes is seen in someone that has ARVC as well. So in these conditions, whether it's ARVC or HCM, any of the conditions, you're trying to figure out, does this person need an ICD or not? And the way to think about this is, if their disease is really severe, then yes, they need an ICD. And how do you think about if this person has severe disease? Well, if they've had a previous cardiac arrest, that seems pretty bad. So let's give them an ICD. If they've had syncope, so imagine someone who doesn't have any symptoms, they come to you, that's very different than someone, I've had syncope several times. That might be a precursor to somebody having cardiac arrest. Somebody who has hemodynamic compromise, compromised function on an echo, or left ventricular involvement. Like we said, in ARVC, it predominantly will hit the right ventricle, but if it starts to hit the left ventricle, that's again another sign for more severe disease. So we've talked a little bit about HCM here just a little bit ago. It's an autosomal dominant disease. It affects the sarcomeric contractile protein, so as opposed to the desmosomes, now we're talking about the sarcomeres. And in this disease, it oftentimes will hit the left ventricle, so left ventricular hypertrophy. And a common thing that you'll see on pathologic slides is something called myocyte disarray. That's another buzzword to remember for your board exam. So myocyte disarray, that should clue you into they're talking about HCM. And people several years ago thought, well, the classic way to try to diagnose HCM is to really think about hearing this classic murmur. And the murmur would be associated with left ventricular outflow obstruction. Well, it turns out there have been some good studies that show that the left ventricle outflow obstruction only occurs 25% of the time. So the reason for that is the left ventricular hypertrophy, as we saw in that picture a few slides ago, that can actually occur anywhere. It can occur up high and cause that outflow obstruction, or it can actually occur down at the apex, of which you would never hear a sound when you're listening with the stethoscope, and that can still lead to sudden cardiac death, and it's still dangerous with HCM. So it's important to know that outflow obstruction does not occur all the time. So again, if you're trying to stratify people and figure out, do you need an ICD or not, you're trying to figure out, does this person have really severe disease? And so things, again, like syncope, family history, people dying really early, abnormal blood pressure response during exercise, do they have an echo that shows huge hypertrophy, like 30 millimeters? Those are things that are going to, if you have 2 or more of those, they're going to buy you an ICD. So in hypertrophic cardiomyopathy, if you look at people's ECG, some of the common things that you might see are T-wave inversion. Oftentimes you'll see them in leads like V3, V4, V5, V6, or 1 in AVL, for example. And this deep T-wave inversion is very classic for HCM. And you might see Q waves. We'll show you an ECG here with in a little bit. But the T-wave inversion that we had on the previous slide is very different than this pattern. And I wanted to go over this ECG with you of people black or Afro-Caribbean descent that have this ECG pattern where there's an upsloping that is sort of before the T-wave inversion, and specifically confined to V1 through V4. So any T-wave inversion that goes on to V5 and V6, that's abnormal. But in this condition here, specifically in black and Afro-Caribbean athletes, if you have this upsloping into the T-wave inversion, this is actually, from the studies that we've seen internationally, this is categorized as being normal. So this is a normal variant in black and Afro-Caribbean athletes. Again, different than this ECG that we had just a little bit ago, where you see it's not necessarily you don't get that upsloping before the T-wave inversion, and it extends out into V5 and V6. Did want to highlight the Q waves. So again, this shows that Q waves, again, are something that you might see in somebody with HCM, and oftentimes the Q waves, they're really deep, so that helps you decide that someone has HCM versus someone who does not. So moving on to Marfan syndrome. So a question you might get during the PPE for athletes, you look for non-cardiac signs of cardiovascular disease. So which of the following is a physical finding of Marfan syndrome? So thumb sign? Yes. All right. Elbow hyperextension? Fibrillin 1 mutation? Yes. And pes cavus. So this is again, we're looking at physical finding. So the answer is thumb sign on this one. So with Marfan syndrome, it is a mutation in fibrillin. You're going to look at 3 key areas in the body: cardiac, the eye, and the skeleton. And from a cardiac standpoint, the thing that you're going to worry about is cystic medial necrosis that's going to result in aortic dilatation, and it could lead to dissection and rupture. And unfortunately, 50% of undiagnosed patients die by the age of 40. So the inheritance autosomal dominant, so similar to HCM, Prevalence about 1 in 5,000, and you're going to see this often in sports where people are tall individuals. So basketball and volleyball, those are the people that you're going to look for as to whether or not they might have Marfan syndrome. And then exercise is actually going to increase the aortic pressure that you might get, and that can actually expedite the pathology for sudden cardiac arrest. Presentation for aortic dissection, you probably remember the classic tearing or ripping. You might get aortic valve incompetence leading to heart failure. And then on the physical exam, the thumb sign is part of something called the Ghent nosology. So it's important to look those up if you want to know about Marfan syndrome. But the cardinal features are, do people have aortic root aneurysms or ectopic lens? So remember that the eye is one of the 3 key areas that Marfan syndrome affects. So the big thing to remember here is that you're going to do aortic surveillance. And if people have an aortic root diameter greater than 50 millimeters, that's when you're going to think about aortic root replacement. There are some studies that show that ARBs may help prevent complications, and right now beta blockers, there's sort of unclear benefit that we know of in this disease. But the one that you're probably going to think about and that the papers have talked about recently is that aortic root diameter, so remember that. We've talked about Wolff-Parkinson-White a little bit. That's where you have an accessory pathway between the atria and the ventricles, and that can lead to sort of a short circuit. This, right now, the prevalence is about 1 in 750, and I think this is probably an under-recognized common cause of sudden cardiac arrest in athletes, and we'll talk about why I think that here in a little bit. So people can present with palpitation, syncope, or dizziness, but some of the things that you might see on a test question is going to be under the ECG part here. So the 3 common findings that you'll see will be a short PR interval, a delta wave, and then a prolonged QRS. Those are the 3 things you're going to see in the stem of your WPW questions. And then what's important to do with these athletes is to figure out the refractory period. So if you think about the conduction, if you think about things like AFib, if the ventricles are going at the speed with which the atria are going, that's a bad thing, and that can lead to death. But if you have a refractory period that's longer, that's going to actually be, that'll be in the athlete's favor. So it's important that when you do these EP studies that your cardiologists try to figure out what's the chance of them having a high ventricular response, and that's going to be assessed through this refractory period. So this is an ECG that shows you that delta wave. Again, short PR interval, delta wave, and prolonged QRS are some of the common things that you want to think about with WPW. So if you can, you'll ablate these for those who have a high-risk pathway. And then there are different studies. So your classic question will probably say, how long do you keep the athlete out after an ablation? And I would think I would put down 3 months. But it's interesting that when you read some of the papers, it's really variable. Some people will have athletes go back in 2 weeks. So I don't think that'll necessarily be a question, but if I had to choose a response, I would pick 3 months on this one. So Brugada syndrome, this is another autosomal dominant disease. It's due to sodium ion channel disorders. And what you're going to see is a partial right bundle branch block pattern with a coved ST segment. And I'm going to show you pictures of those here in a little bit. Unfortunately, you have a propensity for fatal arrhythmia, so this is another potential cause of sudden cardiac arrest. So Brugada has 3 different types, and the types are here in your handout. You're going to see the diagnostic one on type 1 to your left, and then you have your saddleback on the right side with type 2 and type 3. But the one that you'll oftentimes see is this type 1 Brugada pattern with a high takeoff and then downsloping ST segment. Now that looks very similar to this ECG that I'm going to show here. This is incomplete right bundle branch block, and the difference here is that you can see sort of the skinny, it's not that downsloping prolonged segment that you saw earlier. But this is a common finding, incomplete right bundle branch block, and this is normal. So what you're trying to do here is distinguish between the 2, Brugada and incomplete right bundle branch block. So what I did here on this page is try to show you the difference between the 2. And what you'll see here is that's the Brugada pattern. And then this is where you'll oftentimes have voltage with the S wave that's equal to what's in the QRS segment. And then it's not necessarily delayed as what you're going to see in the Brugada pattern on the left. And then you may see this high takeoff here, but it's not sort of that down sloping into the T wave inversion that you see on the Brugada to the left side. So people with Brugada syndrome, unfortunately, they tend to die at slower heart rates, oftentimes during sleep. And if you think about athletes who work out, athletes tend to have bradycardia because they're conditioned. So unfortunately, this is something that they tend to die because of the slower heart rates. So it's interesting that happens in Brugada syndrome. The other thing that can happen when you exercise is it can increase your core body temperature, and that's another trigger for Brugada, sudden cardiac death in Brugada. So for people with Brugada syndrome, you're going to have them abstain from athletic activity, and again, thinking about if they have high-risk features, whether or not they need an ICD. So people who've had sudden cardiac arrest have ventricular tachycardia or syncope seems to keep coming up as one of the things in HCM, ARVC, Brugada, for example. Some of the newer diseases that you may not have heard about, but are potential ones that you might see on the boards, CPVT, so catecholaminergic polymorphic ventricular tachycardia. The buzzword here is it's a mutation in the ryanodine receptors. So ryanodine receptor is oftentimes going to be in the stem of your board question. And again, unfortunately, intensive exercise or stress is a trigger for cardiac arrest in these individuals. You're going to see PVCs oftentimes I'll show you an ECG that shows the PVCs. You can take beta blockers and try to avoid physical activity in these individuals. And this is somebody who's undergoing an exercise stress test for the diagnosis of CPVT, and you'll see the polymorphic ventricular ectopy that you see in this exercise test. This is some of the common findings that you might see, but the ryanodine receptor is probably the one that'll be in your stem. Long QT syndrome, so depending on the type, it could be autosomal dominant or recessive, could be sodium or potassium channels, but remember it's an ion channel disorder. And the stem that you might see, someone might talk about a young female swimmer that has cardiac arrest due to an adrenergic surge when somebody dives into the water. That might be your classic test question stem. So of the 12 types, there are actually 3 that account for the majority of diseases. Long QT 1 and 2 are due to abnormal potassium channel disorders versus long QT 3 is the abnormal sodium ion channel disorder. And it's interesting that long QT1 is more likely to have arrest during exercise versus long QT2 or 3 would be while they're asleep. So symptoms are very typical to what we've seen earlier, the palpitations, dizziness, and syncope, but the important thing are these things coming up. So remember this clear diagnosis cutoff of somebody who has greater than a QTC greater than 500 milliseconds. And I'm going to show you how to calculate the QTC soon. We normally get exercise testing, Holter testing, and then genetic testing to figure out who in their family or to help diagnose a disease. That's a diagnostic yield of 70%. So what you want to take away from the prolonged QT or long QT syndrome is something called Bazette's formula. So Bazette's formula helps you figure out the corrected QT interval. And the way that you do that is to have the QT, which is going to be in milliseconds, over the square root of your RR interval, which is in seconds. And that's going to give you the cutoff here. And again, if it's over 500, that's a very clear diagnosis of long QT syndrome. But Bazette's formula helps you calculate the corrected QT interval, and that's important. So people with prolonged QT, you're going to have them avoid sports. You can treat them with beta blockers, and I'll show you a study from Dr. Ackerman here at Mayo, who's done some really good work in trying to get athletes back to sports with beta blockers and potentially ICDs. Again, if people have high-risk pathways, those are things like having syncope, as we've talked about earlier, or having the long QT type 2 or type 3. Those are some of the high risk diseases within long QT. So another disease, LV non-compaction, is sort of a newer disease that people have been talking about over the past few years. It's a cause of cardiac arrest, and what this is showing you is trabeculae, and that's the trabeculae are the more common feature of a left ventricular non-compaction that you're going to see on your echocardiogram. And so that's probably going to be part of the stem, is that trabeculae, if you start reading a question and you're thinking about LV non-compaction. This is an example of somebody who had LV non-compaction, and what you can see here is an abnormal ECG, and what I'm showing you here is sort of the ST depression that might be associated with LV non-compaction. So we're going to talk a little bit more about some things that may help you in your practice, as well as some things that you might see on the test. But this is sort of a classic. I don't know if you guys know about Hank Gathers, but this is sort of the thing that helped start sports cardiology and the move to prevent sudden cardiac arrest. This is a very unfortunate incident. Happened in 1990, so about 27 years ago. He goes down. People think that this might be, since he's having seizures, this might be a neurologic event rather than a cardiac event. You can see that they don't really do a good job of getting an AED out there. When they do, they don't use it. This is actually, and this is in a televised game in the quarterfinals of one of the conference tournaments. So this is really the thing that started the sports cardiology movement. Again, just had the 27-year anniversary of that death just a couple months ago. And so some of the things that our group has been doing is trying to figure out what are the things that cause cardiac arrest in sort of high school and collegiate athletes. And so we looked at data from the NCAA over the past 10 years, and we actually were trying to figure out what are the things that kill athletes. And something that people don't talk about but actually commonly occurs is really a lot of deaths in athletes. 50% of them are due to accidents. So it's very important. This helped change my own practice in just trying to talk to athletes about safe driving, wearing your seatbelt, not drinking and driving, and those sorts of things. And oftentimes these unfortunately occurred when people were trying to go home to visit family, let's say for Christmas break or summer break, for example. If we shift into the cardiac disorders, over the 10-year period, we had about 80 cardiac arrests or cardiac deaths that occurred. So about 15% of the deaths, it's the leading medical cause of death during exercise. And so if we look at it, the overall incidence that we found in collegiate athletes was about 1 in 50,000. And you're going to see that certain populations are a little bit more at higher risk compared to others. So about a 4-time elevated risk in males compared to females, and African Americans were at higher risk compared to Caucasians. Here, if we look at sports, we found that basketball had the highest risk. So if you're trying to think about screening certain sports or where do I start, basketball might be the one to start with. And actually, 50% of the deaths in that cohort were athletes who played either basketball or football. So if you're going to start somewhere, those might be the sports to start with if you're doing an advanced cardiac screening protocol. And over time, we've sort of done a meta-analysis of how often cardiac arrest occurs in high school and college athletes. So in the college population, what the literature shows is that occurs about 1 in 50,000 athletes. And in high school athletes, we found that it occurs at about 1 in 80,000 athletes. And this is very different than maybe studies that came out about 15 or 20 years ago, where the rates they thought were in the 1 in 200 or 1 in 300,000 range. So just wanted to show you that what some of the more recent literature has shown. So what diseases actually kill athletes? People might remember 10 years ago, this is sort of the classic study where it shows that hypertrophic cardiomyopathy might be the leading cause of death. But if you sort of examine this study and then put it into perspective with other studies that have been done, both nationally and internationally, you find some interesting things. So when these guys did this study, they had 1,866 deaths, of which 1,049 were cardiac. And then you'll see here that they found a huge group, so about 350 of those, where they didn't know what caused the cardiac event. So they actually excluded those. And then of the 690 that were left, hypertrophic cardiomyopathy was the leading cause of death in their cohort. But what about those 359 that we didn't account for? Well, they actually fall into a group of what we categorize as sudden unexplained death. What that means is the heart looks normal, but we don't really know what caused the death. And as I talked about earlier, this is where I think things like WPW or ion channel disorders, they may play a more common role in sudden cardiac death than we previously had imagined. Because when you start to do autopsies on those individuals, it's really hard to find the ion channel disorder or an electrical disease that might have caused that death. So this is from our 10-year data with NCAA athletes, and actually sudden unexplained death was the leading finding that we had. And if you compare that to some international studies, things that have been done in the UK, actually the military, and lots of other studies, they actually found the same thing where sudden unexplained death was the more common finding. And then this is a meta-analysis that we did with some folks from Stanford, and we found that sudden unexplained death occurred about 30% of the time in athletic groups, versus HCM was a little bit lower at 10% when you included all of the different causes of cardiac arrest. So are there ways to screen for diseases? So part of our role as sports physicians is to do the PPE. And so if we look at the PPE, the main purposes of the PPE are sort of laid out by different organizations. So the IOC, they'll tell you that the periodic health exam is to screen for injuries and medical conditions that might place an athlete at risk. The PPE-4 will tell you the goal is to identify potentially life-threatening or disabling conditions and then modify risk factors. The American College of Cardiology will say that the ultimate objective is to detect silent cardiovascular conditions that can lead to cardiac death. And then the AHA says the principal objective of screening is to reduce cardiovascular risks in organized sports and enhance safety. And so there's really not any debate. All these organizations say that we should screen for cardiac disorders. And if you think about the incidence we thought, 1 in 50,000, 1 in 80,000, you might think that is low depending on how you look at it, or you could think it's high compared to what's been previously reported. But it's interesting that the prevalence of diseases, so the number of diseases that are out there that could kill people, it's actually in the order of about 3 in 1,000. But not all 3 in 1,000 actually die. So we need to figure out what is it that causes that translation from 3 in 1,000 that have the disease to the 1 in 50,000 per se that might have a cardiac death. So the American Heart Association updated their more recent statement. So 2007 was their scientific statement, and they came out with one in 2014. And what they did was they tried to update their essentially their history in physical form. And so the 1990, so this is the third iteration, 1996 and 2007 are to the left, and then 2014 is what they had updated on the right side. And what they've done is simply added 2 questions, looking at prior restriction from participation in sports, and then whether an athlete has had prior testing of their heart, or something that's been ordered by a physician. So that's just important to know. And then if you look at the PPE-4, which is a little different than that AHA document, the comparison of the two I've laid out for you guys. They are very similar. I would say that the PPE-4 is actually a little more comprehensive than the AHA statement, as you can see on the right side. And so if you're going to use the history and physical and you're trying to figure out what are the questions that I should ask people, what are the examination things that I should do, this is a 2-part series that came out in the Current Sports Medicine Reports. It's freely available online. It gives you what questions you should ask, what tests should we order for athletes when they have an abnormal response. All of that's available. So just for your clinical practice, if you're thinking about it, this is a tool or resource that might help you, and I would say look that up, and hopefully that can assist you in your PPE. So how good is the current PPE? Well, the current PPE, unfortunately, has not been a good screening tool. So this is a study done by Barry Marin where he showed a cohort of athletes. 115 received the standard PPE. Only one was kind of flagged as having an abnormal response, but that person was not disqualified. So essentially, all of the athletes in this cohort died. And again, that PPE did not do a good job of identifying these individuals. And so Barry Marin would say that the PPE has limited power in identifying people with cardiovascular lesions. And so what ended up happening is people started thinking about the ECG and whether that's a tool to do. And a lot of major sporting organizations in the U.S. and internationally have started to advocate for an ECG. And part of the problem for an ECG is there typically have been a high false positive rate. So early studies show that the false positive rate was as high as 40%. And so as a screening tool for an ECG, that's not necessarily a good thing at 40%. But the way that I think about it is if you order a complete metabolic panel, so CMP, how do you know if any of these numbers on here are normal or abnormal? So that glucose of 95, is that normal or abnormal? How do we know that? Well, the reason that we know that is because we're provided with a reference range. And that reference range is what can help you identify is that normal or abnormal. And your reference range for an ECG is probably very different for somebody who's a 70-year-old athlete on the left versus your 20-year-old asymptomatic athlete. So a 70-year-old who comes in with active chest pain to the ED, that's very different than your 20-year-old asymptomatic athlete. And I think your reference range is going to be different in those two populations. So what we did just to try to see if we could teach people differences in how to read an athlete ECG, we actually put together athlete ECGs and mixed in ones that might have, show you people who might have cardiac disorders. And we actually gave those to people, cardiologists, sports medicine physicians, primary care attendings. We even gave them to residents, family medicine residents, and we said, read these ECGs, and when they're using their 7-year-old with chest pain radar, they don't do a good job of reading these ECGs. The cardiologist did it 85% of the time, they got it right, and then the others about 75% of the time. But if you give them a tool, so this says the cardiologists were better than everybody else, 85% versus 75%. But if you give them a tool, so give them the reference range for what might be normal or abnormal in an athlete, which is what we did here, this 2-page tool, you're going to actually see that every group improved their ability to read the ECG. So think about the complete metabolic panel. Think about being given a tool that shows you what the reference range is. Now even residents are reading those. I mean, it's the first time they received the tool. There were no modules teaching you how to even read the tool, but just by itself, that helped them get to about 92%. So John Dresner led an effort with some international sports medicine colleagues to develop the Seattle criteria, and they helped to show what is normal and abnormal in an athlete. So things that are normal are LV voltage that you'll see, high voltage, ST elevation or peaked T waves. Those are normal findings in an athlete's heart. And if you compare that to this ECG, similar to what we saw here earlier with the hypertrophic cardiomyopathy, where you have the ST depression and the T wave inversion out into V5 and V6, that's very pathologic. So what John Dresner did and the other folks internationally, they developed a module. So I don't think it's good enough just to have that 2-page tool. I would say do modules to help teach you. And they're free modules that are available on BMJ. Takes you about 4 hours to do maybe, but really good modules, really comprehensive. And a lot of that information got, if you need additional help, actually the Seattle criteria got embedded into this thing called a cardioscreen machine, and that actually reads athlete ECGs for athletes, not using the 7-year-old with chest pain criteria. Chad Asplund, who you guys have heard from this morning and you'll hear from this afternoon, he was part of this group that helped refine the ECG interpretation criteria. And there are sort of some new criteria that have come out, and so these are in your handouts. And the way that I think about these are sort of in a red light, yellow light, green light system, where green light are the normal findings, yellow light, let's take a look. If you have 2 or more of these findings, that's probably abnormal, and then red light, absolutely abnormal. And that's available in your handout. And again, those in the red or those with 2 or more yellow, those need further investigations. And then I left there for you just what are the common findings, so things like incomplete right bundle branch block, sinus bradycardia, early repolarization. I left these just so that you guys know what normal findings in athletes would be. I think John Dresner and then Dr. Fran O'Connor, who you're going to hear from later during this conference. Fran's an absolutely amazing and accomplished individual. They've done a lot with trying to, because there's quite a bit of debate on whether to use the ECG or not in sports for athletes, but I think these guys have done a really good job leading the AMSSM in trying to understand the current evidence for screening, what are the knowledge gaps, and maybe what are some future directions. And I didn't want to go through the whole executive summary, but I did want to give it to you in case you wanted to read it. The big things from the AMSSM position statement that just came out on cardiovascular screening is that the AMSSM supports individual physician autonomy. And so what you'll do is you'll assess what are the populations that I have and what are the resources that I have within my institution, and then you make your screening recommendations based off of that. But recognize that the expertise within Mayo might be very different than what you have in a rural town in another place. So just kind of recognize that those differences might occur. And so if you're trying to think about infrastructure, this is probably the biggest limitation for people who are trying to do ECG screening. And so what I put in your handout here are some things to consider if you're going to do an ECG screening program. So am I going to screen all athletes or just the high-risk ones? If I'm going to do it, am I going to do it in a station-based format, or am I going to get the ECGs off-site and then have them bring them to me? Am I going to use the athlete-specific criteria? Have I discussed this with key stakeholders within my organization? What am I going to do if I have an abnormal finding? Do I have cardiologists that can support me? And then am I going to always commit to quality assessment and improvement? Because your false positive rate might start out at 5%, but if you continually assess yourself, maybe you can get that down to an even lower number. So these are just some key considerations with infrastructure. And then along the lines of infrastructure, if you have somebody that gets diagnosed with the disease, we found that there are some psychological ramifications, and that's for, forget the ECG or not. If you diagnose somebody with a cardiac disorder, as I talked about earlier, imagine the viral myocarditis athlete that had nothing to do with an ECG. That's just somebody who comes to you as an athlete. There are psychological implications for being held from sports or being disqualified. So imagine your career ending and it's not voluntary. And there are different stages that people go through in terms of what their immediate reaction is, how they cope with it, how they adapt, and ultimately what happens in the long run. So I would definitely have mental health individuals who can help sort of deal with the potential psychological ramifications. So again, kind of just wrapping up with some of the ECG stuff, with the diseases we have, we don't know what the natural history of many diseases are, and we don't have outcomes-based data about what happens to those individuals once they're diagnosed with the disease. So the million-dollar question is, does early detection actually lead to a reduction in morbidity and mortality? But there are some studies that show that exercise can increase your risk of having arrhythmias or impaired cardiac function. So if you extrapolate from other studies in ARVC or things like long QT syndrome, you don't know what happens in people who are diagnosed through an ECG, but you can extrapolate from other studies. And so early detection is actually important. And as I mentioned here earlier, actually some people from Mayo, Jonathan Johnson and Michael Ackerman, showed that when you find somebody and you do the appropriate medical intervention, so give people beta blockers when they need them, give them ICDs when they need them, you actually have a really low rate of cardiac events. So, and that's in long QT, and then also in diseases like hypertrophic cardiomyopathy. You can see down here from an Italian study, the last line shows you that early detection of HCM led to a 73% reduction in mortality. So I think that early detection is important, and so in my practice I would use an ECG. And I think it's some of the studies that show that it may be beneficial to reduce risk through medications or ICDs. That's kind of where I go with it in my practice. And so you're going to see some studies that have come out more recently. Rachel Lampert from Yale, she's talked a little bit about athletes who are actually playing sports with ICDs. You're going to see some emerging research that looks into whether or not it's safe. And in her study, she's shown that it actually can be. So as we get to the tail end here, I don't think screening is the end-all, be-all. I think it's important to have emergency action plans. No matter what you do with screening, you might have events like commotio cordis, and you need to have AEDs and emergency action plans. And so simply having an AED is not enough. You need to have a checklist. You need to have a written emergency action plan. It needs to be coordinated with your EMS staff. And so all those things must be important. And as we saw in the case of Fabrice Mwamba a few years ago, he'd actually been through 3 ECGs and he still had a cardiac arrest. So important to have your emergency action plan and your AED programs. So to conclude from the sports cardiology section, it's important for sports medicine clinicians to have a good understanding of the abnormalities that might lead to arrest or death in athletes. Screening, whether you use the PPE or an ECG, it's an important part of our training. And I think educating yourself and preparing, using infrastructure, those are going to be important as you try to optimize outcomes. Thank you.